Hi everyone, very good evening guys, and welcome back to the next day. And we are going to have two sessions today and tomorrow for pathology, specially targeted for the upcoming May INI-CET. So today I decided, because since INI-CET gets you a lot of questions related to hematology, and that is a part of path which we tend to read towards the end, so we always have a lot of doubts, confusions, be it RBC images, flow cytometry, platelet aggregometry. So these are the kind of images we have to go through once before the INI exam, and that is what is planned. Also, since yesterday many of you asked me that what are the videos that we should be going through at this point of time. So I'll exactly take a minute before I start this session, and I'll tell you what all to see in this limited time frame that you have, right? And Dr. Chirag, definitely the FMG students will benefit from this session. So of course, this is going to be for you guys also, undoubtedly. So Abhi, because you have an INI exam coming up, what should you be watching? For pathology, guys, I've given you in order of importance. Now go as per how much time you've left for pathology and microbiology. So first, I would request you to go through the NEET PG marathon, and this session that I'm going to conduct today and tomorrow, that is like topmost priority that you have to do. Both these sessions are available on YouTube, right? After that, if you have any time and energy left, you can go through the one-liner session that was conducted before NEET exam, but that is lesser in priority. The first two things you have to go through. Same goes for microbiology. Micro, maybe first you have to give importance to the NEET PG marathon and the image session that we had yesterday, and then if time permits, you're going to go in for one-liner session. That is what you do. If you've kept like half a day for path and micro, this is what you do. In case you've kept one day, then my advice is go through the rapid revision that has been uploaded on the Prepladder app, and that is definitely going to help you. So yeah, this is what you have to do, and I hope the confusion is sorted. Right? Chalo. Now coming back, what are we going to start off with today? Let's begin with the hemat section that I'm talking about. And let's begin with question number 1, which is a direct repeat from the previous year papers. The following peripheral smear finding is associated with how many alpha gene deletions? Now, firstly, alpha gene deletions means I'm talking about alpha thalassemia. And this is a very classical picture that they have. Answer I've already got, and that is going to be 3 alpha gene deletions. So what exactly is this picture? Before I start, whenever we are going to be talking about alpha thalassemia, please note that alpha thalassemia is absence of genes. Genes are not going to be mutated. Genes are going to be deleted. It is a gene deletion. Very good. Everyone's right that this is a golf ball inclusion. So before I come down to this picture, quickly in 30 seconds, complete this table for me once. Then I'll tell you what that image was showing. So normally, a person who's normal has how many alpha genes? A normal person has 4 alpha genes, and 4 4s are 16. So they are present on chromosome number 16, right? So normally you and I, we have 4 alpha genes. If one alpha gene gets deleted, it is really not going to make much of a difference, and that person is going to be asymptomatic, not much of a problem. If 2 alpha genes get deleted, that is said to be alpha thal trait. And you all know that if alpha thal trait marries another alpha thal trait, then the future generation can certainly have a problem. So this is what we have with 2 genes deletion. So remember, 2 gene deletions, thal trait, TT thal trait hoga. Here comes the next question. If 3 genes get deleted, that is when the real problem happens. So tell me guys, normal hemoglobin, like in you and I, adult hemoglobin is what? Alpha 2, beta 2. We all know this, hai na? I am saying alpha genes are not there, alpha chain is not coming. So this poor beta is left alone. So what does this beta do? Beta says, fine, I will complete my valency on my own. I will make tetramers. This is beta 4 tetramers. And this special hemoglobin is known as HbH disease. This is the picture that I showed you. This shows you the presence of golf ball inclusion. So simple, its partner went away, alpha partner went away. So beta decided that I will get over this breakup by spending time with my own self, and that is how you learn this. So what is this going to be? So remember, he who is a boy, he matlab I'm talking about hemoglobin H disease. Who is a boy means I'm talking about beta 4 tetramers. He is very, very depressed in life because his partner, 3 alpha genes have been becoming minus. 3 alpha genes have been deleted. So how is he overcoming this breakup? By playing golf. And that is known as these golf ball inclusions. Now tell me, the previous year question was this. So he who's a boy, he's getting over his 3 alpha breakup by playing golf. What is this stain? That is the next year question that came in INI-CET. And this blue color stain is new methylene blue. Anywhere else in pathology and hematology where we use new methylene blue? Very good. Dr. Arun says supravital stain. Bilkul, it is a supravital stain, new methylene blue. Reticulocyte also uses the same one. Golf ball inclusions will also use the same one. And that is what I talk about. This is a much expected question. Last one, if all the 4 alpha genes end up getting deleted, this is not compatible with life. This is going to be intrauterine death. It is a hydrops fetalis. And what is this hemoglobin going to be? Fetus. The fetus will die. Fetus ka kya hemoglobin tha? Fetal hemoglobin. So now alpha is not there. So gamma 4 tetramers are going to form. And gamma 4 tetramers is referred to as HB Barts. So how we've learnt it as that Barts is going to be barbad fetus. The fetus is going to be barbad, means it's going to be an intrauterine death or a stillbirth. So HB Barts is gamma 4 tetramers. Entire slide is done. Coming back, your golf ball inclusions, how many alpha genes deleted? Playing golf at 3 a.m. 3 alpha genes are going to be minus. That is HBH disease and that is beta 4 tetramers. This is the first thing that has been done. On the same lines, right now all of you were telling me supravital stain and stuff. So tell me something more about it. That's your next question in continuity. They love giving you these practical based questions in INI-CET. So this is the next one that you have. Which of the following steps will not be included in the staining protocol of the image shown below? Right? Right. And someone said that I look exactly like new methylene blue today. Probably yes. So yeah, what is it? Which of the following steps will not be included in the staining protocol shown below? This is the cell that you were talking about, and that is what? That is a reticulocyte stain, right? So reticulocyte jo cell hai, what is the stain that we are talking about? Yes, new methylene blue, supravital. This is not included. So what is the supravital stain? It's time to get into the details. I'll come back to the question. This is the cell, reticulocyte. Quickly tell me some bullet points about it. What is the normal count? It is 0.5 to 2%. Some books say 0.5 to 1.5, some say 2.5. I've taken an average and given you an average number. 0.5 to 2% is the best answer that you can do for a normal retic count. Okay, right now you told me it's a supravital staining and these are the two examples, new methylene blue and brilliant chrysal blue. Matlab some blue color stains are there and that is why the reticulocyte is coming out as all blue. So what are these blue color dots? If someone asks you what is the composition of a reticulocyte that you have, what are these blue color dots? So remember, R for reticulocyte and R for ribosomal RNA. It is made up of ribosomal RNA. That is very important. Yes, so composition bhi ho gaya. Now comes what is the meaning of supravital. See guys, you're wanting to stain RNA. RNA will never ever be stained if you tend to fix the cells. If you treat the cells with alcohol, methanol, ethanol, all these compounds, RNA will not pick up the stain. So make sure there is no methanol fixation. You do not do any fixation. Rest you will take blood, you will take new methylene blue, everything is the same, but no methanol fixation because vitality is important. You have to maintain the vitality, and that is exactly what I had asked you. What all are you going to do? Are you going to add new methylene blue and brilliant chrysal blue? Yes, they are definitely supravital stains. Will you add equal quantities of blood and stain? Yes, it's a 1:1 protocol, but what you're not going to do is methanol fixation, and that becomes the answer over here. Excellent. Many of you knew this. I'm going to tell 30 seconds mein how another question can come on this is in front of you. It's the same picture, but now they've asked you and twisted it an image with a different option. So we'll quickly go through reduced energy fatigue in a 43-year-old female who's having hypochromic microcytic hypochromic anemia. She had stable angina for which she was given drugs. Iron supplementation was also prescribed in her, and a peripheral smear later on showed large blue cells on right and gymsa. Then a special stain was done as shown below, and they've asked you the composition. So reticulocyte ka composition I just now told you with ribosomal RNA, and this is the last variety that this question can give to you. So all in all, new methylene blue se related all your questions are done. Confident? Good. Shall we move forward? Before I put up the full question next, help me a little. I've given you half a question. Can you fill in the blanks? Because then I'll continue the rest of the MCQ. I have a question in front of you. There's a patient who has increased ferritin, increased iron, increased transferrin saturation, decreased TIBC. Can you first tell me the most probable diagnosis on the basis of this? Dr. Siddharth, just hang on because I have a few more images left. I'll definitely cover the supravital stains. Okay, many of you said IDA. Guys, in iron deficiency anemia, are you increasing the iron? You said it iron deficiency. How can you increase iron, increase ferritin? You're increasing everything and calling it iron deficiency. Some of you saying AOCD. No, guys, this is a case of sideroblastic anemia, because now I think, although it's not an image based question, the image will come in the next slide. I think it's important that now this confusion came up, so jaldi se make this table for me, and this will help you a lot in the INI exam and even the FMG exam. You have three things: iron deficiency anemia. Remember the word, everything has to be low. It is a deficient scenario. Sideroblastic has sidro, so iron has to be more. The word sidro is telling you iron will be in excess. So now tell me, in iron deficiency, the iron of course will be low. If iron is low, obviously the transferrin saturation is low. Ferritin is storage form of iron, right? So storage form of iron also has to be low. Everything is low means iron, transferrin, ferritin. So the capacity, the hunger for iron is going to be very, very high. Total iron binding capacity is high. So this is a very, very poor person having no iron in the body and having a lot of hunger for iron. Ye wala section clear hua? Because now sideroblastic is the opposite. Sideroblastic is overload situation, means iron is going to be very, very high. Saturation will also become high. The storage will also become high. This is like multi-millionaire. This is like Ambani, has so much of iron, has so much of money, has so much of everything in abundance, that overall the hunger is going to be very, very low. So total opposite scenarios you have discussed. One is a deficient scenario, one is an overload scenario. Now where does the confusion come is in this: anemia of chronic disease. Have you heard my previous lectures, and have you heard anemia of chronic disease is that pseudo beggar whom you find on the roads these days, who will tell you that he has no money and no money to eat food, but he's actually richer than all of us because he is earning so much by begging on the roads. That is anemia of chronic disease. He will show you that he has no money, but he has a better house and a better bank balance than all of us. Means he will show you that he has no money. Iron, he will show, I have no iron, I have no transferrin saturation. He's showing that he's very, very poor, but actually when you go and open his bank account, he is richer than all of us. His bank balance is very, very high. The ferritin is high, and that is how you differentiate. Dekho, iron deficiency was also low, AOCD is also low, but AOCD is a pseudo beggar because his bank balance is very high. And because he has a lot of iron in his bank balance, obviously his hunger is going to be low because he knows I have a lot of money in my bank account. I will be able to use it as and when. Okay? So remember, anemia of chronic disease is the pseudo beggar whom you're seeing on the roads nowadays, showing he's poor, but actually he's very, very rich. Iron deficiency anemia is bichara genuinely poor garib person. He has no iron, no money, nothing. And sideroblastic anemia, overload. He's the Ambani of the family. He has everything in excess. Just in case you forget this story in the exam, TIBC itself is your mnemonic. What do I mean by that? Someone's also sharing their experiences. Mera ek dost aisa, everyone in the hostel and everyone in college is like that. They say they don't have money, but they've done their savings. That's okay. So what is TIBC mnemonic telling you? Top in IDA and bottom in chronic disease. Just in case you forget TIBC during the exam, remember top in IDA, increased in IDA, and bottom in chronic disease, it's going to be decreased in chronic disease. Bhul gaye? So the name will also help you. So now finally guys, tell me, everything was increased. Iron was more, ferritin was more, saturation was more. This was the Ambani situation. That is why the hunger was less. What did you call it? You called it sideroblastic anemia, right? Now tell me, Dr. Zainab, okay, the thalassemia will be added in a while. Okay, so now you've got the answer. Now I'm going to continue the question. The same question, you've told me this is a case of sideroblastic anemia. Now tell me the image-based question. Which of the following peripheral smear findings out of these 1, 2, 3, 4 will correspond to sideroblastic anemia? Will correspond to sideroblastic anemia. Batao, 1, 2, 3, 4 mein se what should I put up over here? That is the real deal that you have to study. Some of you have started saying number 2. Okay, so this is what you're talking about, and some of you say 3. So ye har baar ka every time confusion na, which inclusion looks like what? Once and for all, let's put a flashcard. Answer is 2, by the way. That's the correct answer, because when you're dealing with sideroblastic anemia, iron is more, and when iron is more, this means it forms some bodies called Pappenheimer bodies. So now what we'll do, we'll make a flashcard. This is your flashcard. All the bodies are in one line. How will I differentiate it in the exam? One is of course history and parameters, but how can I solve the question in like milliseconds? How will that be possible? First thing, look at the color of the picture that is given. Fingers crossed, I hope they give you good quality images. Look at the color of the picture given. If it is the usual red color wala photo, matlab they have used the usual Romanovsky, usual hematology stain. If it's a very dull looking grayish kind of a picture, that's the catch. Something different has been used, and that is known as crystal violet. So first, this gray wala, dull wala slide, when crystal violet has been used, is nothing but the Heinz bodies. Because what is Heinz bodies? Heinz bodies is nothing but denatured hemoglobin. When does hemoglobin get denatured? When there is a G6PD deficiency anemia. That is when hemoglobin gets denatured. So hemoglobin has been ruined. Kharab hemoglobin. If it is kharab, if it is ruined hemoglobin, Romanovsky is not gonna stain it. Romanovsky does not stain it. I will need something else, and that's the previous year question. Which of them does not get stained with Romanovsky? Does not get stained with Romanovsky is the Heinz body, because Heinz body is kharab hemoglobin. So one of them is totally sorted. Now I look at the red wala. Ab red wala Romanovsky mein all the cells are red looking. I have to see, are there single bodies or multiple bodies? Have a look at this. If you are seeing just one dot everywhere, one dot matlab this is forever single, yes, happy and jolly to be single. Exam time hai, this body is happy and jolly to be single. So if you see single bodies, you will call it Howell jolly. What is it made up of? Very good. Many of you have told me the answer already. It is made up of DNA remnants. And which disease will you see it in? What is the famous anemia in which you see it? You see it in megaloblastic anemia. And tell me one more thing. Other than anemia, some other situation which is their favorite most question, you also see it in a case post-splenectomy. You see it post-splenectomy as well, right? So that is Howell jolly bodies. Talking about your multiple ... So many multiple are there. These are the Pappenheimer bodies. And you've already told me. What are they composed of? They are composed of iron. And which anemia will you see them in? Abhi we had studied sideroblastic anemia. So come back to the question finally. And this was the question where you had a sideroblastic anemia. So examiner was nice. After giving you the parameters, he's given you the diagnosis. And then of course you had to pick up the multiple bodies, and that was going to be the sideroblastic Pappenheimer bodies. Acha, now first and foremost, these are not the only causes. If you say, are Howell jolly bodies seen in sickle cell anemias, thalassemias, can they be seen in hemolytic anemias? Someone M416, okay, some real PUBG lover is over here and has asked, does hemolytic anemia also show you Howell jolly bodies? Yes, it does. Okay, and I will be using your name in one of the mnemonics quite shortly, so hang on in there. Okay, chalo. What is the next now? Now that we've started this, should we keep a target of 5 to 7 minutes and finish off all the inclusions, all the shapes that the INI-CET exam can trouble us with? Okay, deal. Let's do a 5 to 7 minute target. Time boxing karte hain, and let us start off. And that is how you should be studying right now. Decide 5 minutes, 10 minutes for this topic. Wrap it up. Let's begin. These three we've already done. Okay, now we start off with the next one. What is this in front of you? You can see the figure of 8 appearance, figure of 8, classical caboring. Jaldi for everything, keep telling me. Composition, disease, and finish it off. Composition, it is going to be made up of, it's a patla, thin fiber. What is that fiber? That is going to be mitotic spindle. That is a mitotic spindle, and they ask you in INI, they have asked you which amino acid is it very rich in. It is very rich in arginine. It is very rich in arginine. Which anemia? Again, I'm talking about megaloblastic anemia. Very good. Everyone's given me correct answers. So this figure of 8. But is it always going to be 8 shaped? It is a spindle. It can go in any shape. 8, 0, B, D. So coming to the next. Look at this. Looking the other shape. It can be round also. Ma'am, it's a thread. You can turn it around in any shape as per your choice, right? Okay, now coming to the next one. What is this? The entire red blood cell is having chota, small, dot. Full coverage. See, Pappenheimer bodies were also multiple, but they were not having this full coverage. This is going to have a full coverage. So please remember that is known as stippling, basophilic stippling. Sometimes they can be tiny dots, and sometimes they can be very big dots. So tiny dots can be seen in a lot of conditions like thalassemia, iron deficiency, many reasons known. But the coarse basophilic stippling is their favorite question. Lead poisoning. This is what you had studied for NEET also. What will you study little extra for INI-CET? There's also an enzyme deficiency called 5' nucleotidase deficiency. 5' nucleotidase deficiency can also show you coarse basophilic stippling. Okay, done. Now let's go on to the lots of inclusions are done. One more inclusion was there, I'm not repeating. I've only put it up for completion over there. You guys have already answered it to me. Golf ball inclusion seen with 3 alpha gene deletions. So ये वाला already हम कर चुके हैं. We'll now move on to the shapes. What are the different shapes? This is the classical shape that you have, everyone, the one that you see in pencil cells, and I'd already written because I knew you guys know it, and that shape is going to be seen in iron deficiency anemia. Okay, tell me one thing. If there is a variation in shape, what is it known as? Anisocytosis or poikilocytosis? Variation in shape, I've given you the hint, that is known as poikilocytosis, because if there is a variation in size, then I will be calling it as anisocytosis. So no confusion. Shape wala is poikilo. So when you're seeing a pencil cell is a change in the shape. Shape means this is showing you poikilocytosis. Very good. Coming to the next. This is very simple. Round. This came in the NEET exam. This question came in the last INI-CET. It came in the FMG exam. It's coming everywhere. Goal cells. These are spherocytes. And they will ask you the causes of spherocytes. This is something I was discussing with you yesterday also in one of the microbio images. So tell me once again, what is the most common cause? Yes, autoimmune hemolytic anemia. After that, you will think of things like G6PD deficiency and hereditary spherocytosis. But the most common cause is autoimmune hemolytic anemia. And if someone is hemolytic anemia, if someone is breaking your cells, the bone marrow will fight back with these big cells. What are these? The reticulocytes that you've just studied. You say, ma'am, I don't think this is reticulocyte. You have to prove it to me. I have already done that proof for you. What is the stain that you will do? You will do the new methylene blue stain and you will find out. So this is also sorted. Where did we study it yesterday? Yesterday we were doing cold autoimmune hemolytic anemia and we correlated it with a particular organism that causes cold autoimmune hemolytic anemia. Remember mycoplasma wala question, which was a nice integrated question yesterday. The same picture I had got you over there as well. Okay. Now we move on to the next one, the 3Ds, the troublesome 3Ds that you have. So firstly, if you see that a cell has been, someone is biting the cell. So remember, dog bite, that is known as degmacyte. Keep telling me the diseases. Degmacyte or bite cell is seen in G6PD deficiency. Very important. So you've done everything for G6PD. G6PD ka RBC shape is asked and you will say bite cell. And G6PD ka, if they end up asking me the bodies, then what is the body that you will tell me for G6PD? That is the Heinz body. So everything about it seems to be done. Coming back to my picture, degmacyte ho gaya. The other D is dacro. Dacro anyway reminds me of lacrimal gland. Lacrimal gland means that is going to be teardrop. I can very well see cells are changing their shape into drops of tear, exactly how all of you are behaving right now before INI-CET. Everyone's messaging me, ma'am, rone ka man kar raha hai. Same way, same, this is also crying. RBC is crying. Why? Because RBC is trying very hard to squeeze out of the bone marrow. When it is trying to squeeze out of the bone marrow, why? Because there is a big mesh in the bone marrow. Fibrosis ho gaya hai bone marrow mein. RBC is not able to come out. So this is seen in a case of myelofibrosis. So this is what you guys are. What are you right now? You guys are dacrocytes. Okay? Now finally the last D, which you don't need a mnemonic, drepanocyte. Drepanocyte is sickle cell. No points for answering this, that it is seen in a case of sickle cell anemia. So yeah, you've got the very famous, okay, someone said hairy cell leukemia, Dr. Dark Knight, bilkul theek, because anywhere the fibrosis occurs. So now if hairy cell leukemia shows you fibrosis, then hairy cell leukemia can also show you these teardrop cells. So any kind of fibrotic etiology will show this to you, right? Okay, chalo. Done. 3Ds, dog, bite, tear, dacro, that's you, and sickle, drepano. 3Ds are done. Now let's come to the famous ones that look almost similar. What is this, guys? What do you want to call this? Quick test. Acantho, echino. Kya kara? This is the Ma'am, spiky coming up. This spiky thing has to be spur cell. The spiky stuff has to be the spur cell, and spur cell is known as acantho, because acantho word means spike. Okay, tell me. Ab kal we did microbiology. There is one amoeba which has the word acantho in it. That also looks very spiky. That's a spiky amoeba. Which is it? Acanthamoeba. So wherever acantho word comes, so acanthamoeba also looks spiky, acanthocyte also looks spiky. It's always spiky. That is how it's going to look like. And which disease do you see it in? A for A. It is seen in A beta lipoproteinemia. A beta lipoproteinemia is where I shall find it. A for A, simple answer. Coming to the next one, echinocyte and Burr cell. Pehle E likho and then you can convert it into a B. So echinocyte and Burr cell are same cells, and they are Burr matlab blur. That is how I've learned it. Burr matlab blur. Everything is gonna look blur like this, zigzag. That is going to be an echinocyte. So spiky is going to be acanthocyte, blurring is going to be echinocyte. Kahan dikhega? Very good. You're moving ahead of me. You've told me the answers. It is seen in B for Burns patient. Samples coming from the Burns department always show you echinocytes. Samples coming from the kidney nephrology department, uremia ka cases, U for uremia, they also show you echinocyte. And samples which the intern does not deliver in time to the path lab, that is kept in EDTA for very long, that is EDTA changes. We never call the ward or tell the ward that the sample was not given by the intern, because we believe that the intern is already being shouted at a lot in the ward already. But we know that the intern has not collected the sample well in time. Okay, so sent it to us well in time, that is EDTA changes. B for Burr cell, B for Burns, U for uremia. Done. What is this last cell that is left? This is the direct answer, classical, target cell. They will never ask you target cell in the exam, of course. They will ask you by the other name, and that is a podocyte. This again is seen in a lot of things. It is seen in hemolytic anemias, iron deficiencies, it is seen in so many things. But T for T, so you have to learn. Thalassemia mein, so you have to know this. It is very important. And thalassemia means hemoglobin disorders, na? Hemoglobinopathy. So with that, you can add on all the other hemoglobinopathies like HBC, HBE and all of that. Okay, so hemoglobin disorders mein thalassemia and all target cells are seen. Okay, now finally almost coming to an end. What is this going to be? All the RBCs are broken, ma'am, broken in random shapes. One is looking like a helmet, one is looking totally scattered. This is a schistocyte or fragmented RBC, fragmented cell or schistocyte seen in what? Microangiopathic hemolytic anemia. Give me some example of microangiopathic hemolytic anemias. Where do you see them? HUS, TTP, DIC. Okay, let us do some, okay, some people call it MAHA, same thing. Microangiopathic hemolytic anemia, MAHA, same thing. Tell me, yesterday we did microna, and now that you've spoken about hemolytic uremic syndrome, which is the strain of E. coli that we were doing yesterday, where I was saying hemolytic uremic syndrome, it causes enterohemorrhagic E. coli. Remember we did O157H7, yes, and was there any culture media that I showed you and I said, ye ho sakta hai, this could be an expected question. There was one media which you were asking me, ma'am, SMAC. Sorbitol में conky agar, because sorbitol fermentation is not seen with O157H7. Yes, everyone's giving answers in a line. Super good, very good. You are sorted. Almost done. Agla wala to sabka favorite. You will never forget it. This you remember since your second year days, and that is the rouleau formation. Just tell me the disease. Stack of coins, rouleau formation seen in multiple myeloma. I also have a question on multiple myeloma coming up in a while, so we will discuss more about it. Acha, this is properly like a stack of coins. If it's not properly and it's just clumped together, agglutination just clumped together, so that is clumps like this, not in any stack of coins, chota and bada clumps, that is going to be some disease of agglutination, cold agglutinin disease, and that is what we were correlating some time back. Cold agglutinin disease matlab cold autoimmune hemolytic anemia. In simple language, which antibody is it? It is IgM, and right now you told me, ma'am, it was mycoplasma which was causing this cold autoimmune hemolytic anemia, and that is in front of you. So everything is done. Autoimmune hemolytic anemia will show you round cells called spherocytes, and this cold agglutinin disease, the name only has it, that is agglutination. So all these are clumped together. Coming to the next one, which is something again which is INI-CET special. This is a pincer cell, matlab mushroom wala cell. Mushroom jaisa cell hoga, the cell which is going to look like a mushroom. pincer, I've learnt it as if someone is pinching it out. This is a red blood cell, someone is pinching it out, that becomes pinch wala cell, pincer cell. Just tell me the defect that is there. I've given you half the hint. What is the defect that you see? That is going to be the band 3 defect, right? So band 3 defect is going to be the pincer cell. Sorted. Now let's move forward. Okay, yes, infectious mononucleosis for previous one. I think I got the answers late. Okay, yes, you guys are right. In fact, I have learned कि जो, I'm just going back and taking up the questions, all the MM wala antibodies are here. So all the MM wala diseases are here. Mycoplasma is here, mononucleosis is here, malignancies are gonna be here. Everything follows the MMM in this cold agglutinin disease. ठीक है? Chalo, now I'm almost towards the end. This is the last, and this is also a path microintegration. This is another red blood cell thing that you have. So ye kya hai? What is it? Actually, you studied this in micro, but this is actually a red blood cell etiology. So it's a must that we studied today. Ma'am, this is what kind of a red blood cell is it? Mature to nahi hai. This is a red blood cell precursor. Definitely. Very, very good. Red blood cell precursor. And is it showing you these kind of aisa as if dog ears are hanging out? Everyone, as if ears of a dog are hanging out. Now tell me something. If we say that this is going to show you dog ear projections, what is that? I got a lot of answers but not the right one up till now. It's like dog ears are hanging out, and that is going to be dog ear projections. What is it? Name some virus. It's a micro correlation. So kuch to micro hoga na. Some virus etiology must be there. Very good. So you kind of come very close. Pure red cell aplasia means what? Which virus again? Parvovirus. Yes, guys, which is, now I'll give you a story which I think many of you have forgotten, but it is very important that you remember it. Parvovirus B19, you always tend to remember that slapped cheek appearance, wo to sabko yaad hai. But you forget that Parvovirus B19 is PAR. It is going to attack the P antigen of the red blood cell. So if this is a red blood cell, it will go and attack the P antigen. That is what is parvo. Parvo means P antigen of the red blood cell is attacked, and the red blood cells then start showing you these dog ear projections. After this, you can keep on learning all your slapped cheek appearance, pure red cell aplasia and all of that, but the problem is that it's attacking the P cell. So they ask you, what is the tropism of parvovirus? Parvovirus goes and attacks which part of the bone marrow? Maximally it attacks the PAR, P antigen of the red blood cells. Everyone's okay with this? After this, of course, you know, slapped cheek appearance is every year question that has to come. Now that you've asked me, I want to ask you one more question. Slapped cheek appearance is what disease? First disease, second disease, third disease, fifth disease, sixth disease. Kahan pe dalenge parvovirus B19 slapped cheek? Just a very random, I don't know why I'm asking it, just a random question. Slapped cheek wala jo appearance hai, it is, so to slap a person, obviously you need your 5 fingers. 5 fingers ka slap banta hai na, so of course we all know it is a fifth disease. Perfect. Just randomly I wanted to take a test. Good. All your RBC shapes and inclusions are done, which means we can now move on to the next question, which is very, very important for everyone. And here you go. I actually did not even bother to give you a question on this because you know it's already completed a hat trick. Hat trick ho chuka hai is question ka. Let's see if it comes a fourth time also in the paper. So this time I thought you don't need a question on it. Right in front of you, you have the Gaucher cell. Now, if by chance the examiner is trying to be a little innovative, if he wants to be same monotonous, he will say crumpled tissue paper appearance. That is when he is just wanting to be usual. Crumpled tissue paper appearance, everyone up to rat gaya hai, ma'am, we are sick of it, Gaucher's, and that is glucose cerebrosidase deficiency, right? But now, if he wants to be innovative, he can ask you, where do you see pseudo Gaucher cells? They look like Gaucher cells, crumpled tissue jaisa hai, but it's not seen in Gaucher's disease. And very good, you are right, this is seen in CML. So this could be one advancement to that question in case he wants to be innovative, in case the examiner wants to be dull, boring and monotonous. So once again, for the fourth time, this question might just land up crumpled tissue paper appearance in Gaucher. So this was just a quick review that I wanted to give to all of you. I am now coming to one of the deadly parts, which I'm sure all of you do not like too much, but we don't have an option. Padna padega. Dual esterase positivity. Dual esterase positivity is seen in what? I've got a lot of AMLs in front of you, M2, M3, M4, M5. How easy. Which of them shows you dual esterase positivity? I've got my answer from all. AML M4, this is an all time, while many exams tend to give importance to flow cytometry and big things, AIMS and INI-CET is one exam that takes you into the laboratory and starts making you think of the primitive techniques, which are still, students tend only to think about automated machines. They will want to ask you how is reticulocyte staining done, what is this positivity that you have. Chota primitive tests they love to put up. So those examiners love to do that, and that is AML M4. Right? Now tell me the toughest part. These are the three blasts that I've got in front of you: myeloblast, lymphoblast, and monoblast. Finish this table and then I'll revisit the question. Sabse pehle, how did you identify this was a myeloblast? This is, so everyone is knowing, myeloblast is identified by the presence of OR rods. This is very simple. What are the stains for a myeloblast? One thing is simple, myelo, so myeloperoxidase, number one stain will definitely be myeloperoxidase. Other than that, SBB, that is Sudan black B, and CAE. Guys, just once go through the full form of CAE, then you want to learn it or not, your wish. Chloroacetate esterase. But just know that it is some kind of an esterase that has been put up over here. So chloroacetate esterase is for a myeloblast. Whereas what is non-specific esterase? NSE. NSE is non-specific esterase, and that is going to be for monoblast. For those who've recently gone through the Prepladder ka RR videos, you must have seen in that also I was teaching you monoblast. Yaad rakhna, monoblast, because that will always remind you that monoblast is non-specific esterase and myeloblast is going to be chloroacetate esterase. Now coming back, I'll come back to this lymphoblast story. Coming back, AML M4 is also known as what? It is known as acute myelomonocytic leukemia. It is acute myelomonocytic, which means, ma'am, it has both the things. It has myeloblast also, and for myeloblast you are saying chloroacetate esterase is positive. It has monoblast also, and for monoblast you are saying non-specific esterase is positive. When both the esterases are positive, I call it dual esterase test, and that is why I selected AML M4. Both the esterases are there because both the blasts are there. Sorted with this question so that I can finish off. Your myelomono story is done. I'm left with lymphoblast, and I think I've got a beautiful picture in front of me which everyone is aware of. What is this beautiful picture in front of me? The pink color, but pink is not everywhere. Block. What is this? Block positivity that you're getting as a pink color. Pass positive. Ab now thoda sa, put a little common sense. In the exam, instead of block, they write dot, blot, or blotting. Kuch aisa blot, dhabba kind of terminology is used. It all means the same. Dot, blot, block, sab same hai. As long as it's a pass positivity in the form of these dots, that is going to be a lymphoblast. What am I expecting? Last part of this table and almost done. What am I expecting for pass? Where else is pass going to be positive? Only limit yourself to hematology. Pass mein lymphoblast to ho gaya. ALL to dot pink color we have understood. Where else? Can any AML be positive for pass? Quickly tell me. M what all? 3, 6 and 7. M3, M6, M7, these are the pass positive AMLs, and trust me, this is your final flashcard for all the stains that you have in hematology barring one, because that is not a blast. So that now I'll show you, which you will tell me. Yahan tak samajh aa gaya everyone, and you understood the question also, dual esterase positivity. Now you need to tell me of not a blast, of a mature cell. What is the cell that I stained with toluidine blue? You tell me that answer and your stains ka topic is done. What is the cell that is going to be stained with toluidine blue? So here I've got that cell also for you. What is that? Toluidine blue is the stain for basophils. Basophil and mast cell, agreed. So if you were talking about the tissue, I would have told you mast cells, and if you're talking about the blood, I would have told you basophils. So for both it is valid. Yes, so this is a basophil, the dark blue color wala granules, this dark blue is basophil, and now I have stained it with a toluidine blue over here, and that is what I have. Acha, tell me one thing, since yesterday we were doing microbiology and I was teaching you one mnemonic called TIM. Toluidine blue was used over there also. What was that? What stain was that where toluidine blue, iodine and malachite green was used? Jaldi se bata do. I don't want to write. We've done it just 24 hours ago. Toluidine blue, iodine, malachite green. There also toluidine blue was used, and that was Albert staining. Perfect. Corynebacterium diphtheria. Amazing. That was the toluidine blue that we had in micro. This is the toluidine blue that you have in patho. That is basophils and mast cells. Finally, all the big tension of your headache of your head, the stains are done. So now that you've done the stains, thoda sa let us go into the another question, which is purely image based, and again AIIMS exam loves it. This is the question for all of you. 4 images, and you need to tell me this is a proven case of multiple myeloma, and you need to tell me in which of them do you feel IgA will be elevated. 4 patients, who is gonna have IgA elevation? Multiple myeloma, so don't answer. Multiple myeloma, even I have told you. What, which of them? C and D is okay. Many of you are saying C wala. Why so? Is there any reason? Have you read it, or is it like, no, you don't have, someone's telling me all the names. Guys, tell me the answer. Okay. Names, so I will also tell you in a while. Fine. So answer is D. But now, how do I know? Just by looking at the cells, how can I say IgA or IgM? So please note, if only it would have been asked in multiple myeloma, which is the most common antibody elevated, multiple myeloma mein most common hamesha IgG. Always, for everything, your answer is IgG. Most maximum concentration of which antibody is there in your blood? It is IgG. Which is the most common antibody that you have for multiple myeloma? IgG. But now I will tell you these 4 pictures. Quickly label it. See, firstly we have Russell bodies and Dutcher bodies. Which one is in the cytoplasm? Which is in the nucleus? Jahan pe S wala sound hai. Russell bodies are gonna be in the cytoplasm. Russell bodies are gonna be in the cytoplasm. You can see them over here. Whereas Dutcher bodies, where are the Dutcher bodies? They are in the nucleus. So Russell, cytoplasm, Dutcher, nucleus. And when they are everywhere, they are looking like a mulberry. That is a mulberry or a mott cell. Very good. Coming to the 4th one. क्या हुआ यहाँ पे? Very good. Dr. Arun says, ma'am, flame, vermilion border. So basically, flame, आग लगाना. Whenever we see flame cells, I'm not saying it's specific, but maximum chances are that जहाँ पे आग लगी हुई है, वहाँ पे IgA is the one that is going to be elevated. Again, this is not specific. Doesn't mean that IgG can never show flame cells. Don't take it like that. But if you had to make a guess that, okay, when do I expect that IgA levels are going to be elevated, that is going to be a flame cell. So jahan pe flame means aag, and that is going to be IgA. And you are totally right. This is going to be the IgA ka glycogen rich flaming that has come. So coming back, now you could see which is more likely to be elevated IgA, and that is going to be the flame cell. I hope some of you learned something new, because again, going for INI-CET, little extra edge at times is required, and that we've done. Acha, now what I've seen, these pictures, the students are like pro in identifying. I've seen you identify it in seconds. As soon as I convert these pictures into a bone marrow biopsy, then I feel students tend to falter a little. Why? You are scared of the pink and blue. So bone marrow biopsy also, this is also multiple myeloma. This is also showing you lots and lots of plasma cells. But if I zoom in, you will, and the good news is 99% of the times this photo only comes for multiple myeloma. So you will see the identification part of plasma cell is simple. Where is the nucleus? You will see nucleus is chunked to the periphery, nucleus has been pushed to one side, and that's a plasma cell. You can see some beautiful plasma cells all over in this image. So this is exactly how you will be picking it up. You could get this as a bone marrow biopsy also. Okay, if you had to get this, let me ask you all random associations now. If you had to get this in the form of a clinical question, what would the X-ray be showing, or what would the radiology be showing? Simple kindergarten question I am asking you. कि multiple myeloma का radiology आता, तो that would have shown you the lytic lesions, bony lytic lesions. But if multiple myeloma का kidney would have come, kidney, microscopy of the kidney, do you expect anything that would have been seen in it? So if bony lytic lesions hoga, that you can see over here, very good. This everyone knows. This even second year student in the beginning of his session knows. But this is something that I wanted to add for INI, that if kidney is involved, I think everyone is aware, and I've taught you amyloidosis so many times. You know that in multiple myeloma, there is an increase in amyloid and there's an increase in light chain. So wo light chain kahan deposit hoga? The tubules, can you see this is a tubule and there is some pink cast inside it. Light chain cast is noted. Ma'am, everything in pathology looks pink and blue. How are you calling this a light chain cast? Because see, there are white broken lines. Can you see? It looks as if wo fracture ho gaya. Beech mein se there are tears and there are white broken lines. So it's a fractured cast. It is a fractured cast, and that is how I identify the, so simple, bone may be lysis, bone may be fracture, and light chain cast may be fracture. Har jagah fracture is what you shall be finding. This is if a question comes clinically. If a question has to come from the most usual point of view of the M spike, then I don't want to waste much time on it. We all know this is the M spike. You know that, first look at the blue wala. The blue wala is the usual tracing of proteins, but this is the gamma region. And suddenly over here, the yellow one, I'm seeing that the gamma region has undergone a spike. That is what you see in multiple myeloma. M spike, M band, bilkul theek. But again, my request, multiple myeloma shows you M spike. That doesn't mean the M is IgM. The antibody still most commonly remains IgG. M only stands for myeloma or monoclonal. That is the full form. It does not mean that IgM is getting elevated. The most common possibility is still IgG only. So ye wala is also done. Now remember, sometime back, all plasma cell story done. But sometime back, did I tell you that multiple myeloma can show you something in the red blood cells also? What was that? Multiple myeloma in the red blood cells can show you the stack of coins. So we are now integrated in that aspect also. So multiple myeloma ke red blood cells mein you will see the stacking, that is rouleau formation. Very good. So all of this is done, and I hope the image based question from where we started this entire journey, that is also done. So another part of it definitely gets over. Someone called them poker chips. Yes, totally your wish, whatever you want to call it, as long as you understand it. Let's move on to the next, another high yielding INI-CET topic. I've labeled one particular part of the lymph node, and I've asked you which of the following does not take origin from the area labeled below. Does not take origin. What is that going to be? You have, if you can't see by chance, agar bahut chota font hai, that is the germinal center. It's written as germinal center. So does not take origin from the area labeled below, and most of you have got it right. It is a case of hairy cell leukemia. That does not come from here. This means FL, BL, DL, BCL. What did I say? FL, BL and DLBCL, all of these come from the germinal center. So you know, it's almost again been a hat trick or so. Every INI-CET question somewhere pokes you and comes and asks you about the origin of these different lymphomas. So why now have a problem? Let us actually solve it once and for all. So first you need to know what are the parts of a lymph node. That is most important. So quickly first go through the parts in 1 minute, then go through the lymphomas in 1 minute, and you are sorted. Khatam hai. First and foremost, look at this B cell. Just listen to this story of maturation. This is an innocent B cell. He has not seen any antigen, anything in life. He is a chota sa naive innocent B cell. After that, he enters into the mantle zone. Still also, his mantle zone is unchallenged. You have not challenged it with lots of antigens and all of it. So, abhi bhi it is in the mantle zone. Then it goes to the center, the germinal center. This is the center for a reason. Over here, it's going to get exposed to a lot of antigens, a lot of things. So this is the center where all the exposure will occur to it. After it has gone into the germinal center, exposure ho gaya, what will it become? It will become a post-germinal center B cell. So first it goes into the center. Once it has been exposed, it becomes a post-germinal center B cell. After that, it has a possibility of going into the margin. If it goes to the margin of the lymph node, I'll call it marginal zone B cell. That is some memory it has, and it has gone into the marginal zone. Or it can come totally out. When it comes totally out, it has a memory. It has a memory ke haan, theek hai, in the germinal center I had a lot of exposure that I had. Now I have a memory of that. Last possibility is the B cell comes out and says, I am going to become a plasma cell because I have to make antibodies in life. Basically, yes, medico's life, bilkul. I can give you a story on that also. Simple. Initially, you were small little kids, PMT pass outs, NEET UG, that is naive. Then first you gave your PMT, you were still not very challenged, but then you entered your MBBS, you entered your medical college, germinal center. You first became an intern, that was post-germinal center. Then you had memory for a lifetime. Either you went into the marginal zone, that is, you still stayed there, matlab you did your rural posting, or you decided to come out and you said that, okay, I have memory of it and I don't want to study any further. Or you said, ab mujhe NEET PG karna hai, and all of you have now become plasma cells because you want to do something more in life. Okay? So now, how do I fit in the lymphomas over here? So look at this. Small, naive, small CLL. The small or the naive B cell gives rise to CLL. So CLL, small naive cell से आता है. Who will come from the mantle zone? Is there any doubt about it? Mantle cell lymphoma. So they will never ask you mantle cell lymphoma comes from mantle cells. They will ask you mantle cell lymphoma comes from the unchallenged zone, unchallenged, which has not been challenged. Coming to the germinal center, simple germinal center, say I just now told you FL, BL, DL, BCL. That is follicular, Burkitt's, DLBCL. Khatam. After this, when you're in your internship, post-germinal center say Hodgkin's lymphoma comes. So Hodgkin's lymphoma comes from post-germinal center B cell. After that, it says, I want to go into the marginal zone. No points for guessing that marginal zone lymphoma will come from the marginal zone. Common sense. If it becomes a memory B cell, this is what you have to learn. Memory B cell is going to be hairy cell leukemia. That is something extra you learn. And if it becomes a plasma cell, guys, what is the tumor that arises? Again, very simple, multiple myeloma. So most of them were going with the names, na? Bas extra yaad kar lo. Matlab, the small naive one is the small wala CLL. Mantle zone, mantle cell lymphoma. Marginal zone lymphoma. Simple as that. Plasma cell is going to be multiple myeloma. Ye to obvious wali things the. What are the extra things? Germinal center has FL, BL, DL, BCL. Post-germinal center has Hodgkin's lymphoma, and memory B cell has hairy cell leukemia, and this is most likely going to get you one question in the exam. So I hope you are going to benefit from it. This was the question that I asked you. So what does not arise from the germinal center is hairy cell leukemia, because now you know that it arises from the memory B cells. Very good. So chalo, this one very high yielding topic is also over for us. The next one that I take you towards is going to be first a chota sa test. Let me see, I'm just trying to, this is the question that you have, and you know what I'm going towards. The next part, second last part of today's session, flow hai, and then of course you've got quickly you have to do platelet aggregometry and vaccutainers also. So we've got 2-3 topics left. Jaldi se tell me. This is a dot plot analysis. You have an arrow pointing towards something over here, and they've written something called CD34 and something called 13 and 33. What is the diagnosis that you guys have made? Okay, so quick answers. I can see a lot of CLL coming over here. Okay, so for 34 and 1333, why CLL? No, that's not right. Then I can see some Dian. Many of you are saying CLL. Why CLL, guys? CLL ke markers are totally different. How can you put 34, 13 and 33 for CLL? Not happening. Because I'll tell you, I think before we start off, I thought we'll do this directly, but I believe before we go into this set of questions, CD markers ka revision kar lete hain, because if that is done, then your life is going to be very simple. So there's a long list which we are going to keep a target again, 5 minutes ka time boxing target, and we have to finish off this in exactly 5 minutes. Let's begin. Start off. The first thing that you have to identify, then I have a lot of practice questions for you. Okay, blasts. Abhi, if you remember, I had a session few days back on this as well. Blasts, any blast, lympho, myelo, koi bhi blast hoga. CD34, HLA-DR and TDT. Please, this I'm not giving you any mnemonic. Ye please mere saath rat lo, because that's the first thing you set out to look out for in the exam. Is there a blast involved in the story? CD34, HLA-DR and TDT. What is LCA? LCA is leukocyte common antigen. Every leukocyte is going to have it, whether it is a B cell or a T cell or a plasma cell, every leukocyte will have it, and that is going to be CD45. CD45 is LCA, leukocyte common antigen. Now let's start with the real deal. What is T cells? So simple to learn, CD1 to 8 and 28. 1 to 8, 28. B cells का क्या होगा? For B cells, you have to keep on going double करना. मतलब start from CD10, ma'am 10 का double 20, 20 का 40, 40 का 80. That is how I'm gonna go. 10 का double 20. So in 20s, I'll take a lot of things from 19, 20, 21, 22, 23. That is how it goes. 20 ka double 40. Okay, CD40 is gonna come. 40 double 80. Instead of writing exact 80, I will write CD79A and CD79B. So keep almost going towards your doubles. 10s, then come to the lineage of 20s, then come to the 40s, and then come near the 80s. This is all. Badhate jao. That is all B cell, B cell. T cell kya hai? 1 to 8, 28. Now let's come to natural killer cells. Naturally killing. What are they gonna do? Natural kill. Matlab it's natural killing. Matlab it's got a bodybuilding karta hai. It's got a good physique. It's got a good gym going body. So it's got a 16-inch bicep. It's got a 56-inch chest, and if he's so bulky, then he's definitely got a 94 kg weight. So that is a typical bodybuilder wala physique that natural killer cell has had. 16-inch bicep, 56-inch chest, and 94 kgs weight. Naturally killing, that is why it's so strong. Now coming to the others, and this CD94 was, by the way, your last year INI-CET question only, right? Coming to myeloid cells, अब no points for guessing if you say myeloperoxidase, वो तो common sense है. Now you need to know 1333. Myeloid cells are 1333. That is why the previous question that I showed you, which many of you did wrong, had 1333. When you see 1333, you have to think of myeloid cells. When I come to monocytic, ये सबसे interesting है. Mono sounds like poor single person, forever single. Forever single is mono. So who is forever single? Ma'am, the way you write 1 1 1 and 1, single and single. साथ में 14th February को भी poor person, Valentine's Day also he is very single, and he is single till he dies. So 1464, he is single at the age of 64. Forever single, mono means single. तो 1 14th February को भी single and 64 की age पर single till he dies, right? Okay, done. Now comes mega karyocytic lineage. Where is that student? I want you to, okay, we have him here, him or her. I cannot see the DP of course. M416 auto. So this is your mnemonic, mega karyocyte. PUBG lovers always like it. Mega is for the mega gun in PUBG. PUBG का gun था 416. तो write 416 and then आगे पीछे करो 4161. 4161, and that is going to be CD41 and CD61. So the mega gun of PUBG 416. So 4161 and 4161. 41 के साथ छोटा सा 42 भी add कर लो. 41, 42, 61. तो mega gun of PUBG done. Now let's come to these three. These three are the trio-lymphomas where INI-CET loves to give you a lengthy question, but the answer is in this one sentence of CD markers. What is it? CLL, SLL. देखो CLL, SLL sounds like सब कुछ positive होगा. If I ask you what is the status of CD5, you will say positive. CD23, ma'am, positive. CD200, positive. कुछ भी बोलो, सब कुछ positive. This was your last year INI-CET question. सब कुछ positive. Marginal zone says, अरे I am at the margin. I am not interested in anything. सब कुछ negative. CD5 negative, CD23 negative, 200 negative. Margin is not interested in anything in life. Everything negative. And finally, mantle cell. Mantle cell is only one thing positive, and that is 5. Rest everything is negative. So now it becomes easy to learn. CLL, SLL, sab kuch 523, 200, everything positive. Then you have marginal zone, which is everything negative, and mantle cell is only 5 positive. Coming to the next, what is this? Paroxysmal nocturnal hemoglobinuria. ये तो ऐसे time pass के लिए I have written over here for completion. Paroxysmal nocturnal hemoglobinuria is what? CD55 and CD59 are not there, na? So this I don't think you have to learn. ये तो पता ही है. Now coming to this story, I hope you remember the story of the good boy and the bad boy. The good boy who takes care of his parents, the bad boy who does not take care of his parents. तो ये समझने के लिए I will have to show you one table. Look at this. The story of the good boy, मतलब normal वाले plasma cells, and the bad boy, that is multiple myeloma. Tell me something. Plasma cells are what? You will say, ma'am, plasma cells are B cells only. Ultimately, they are B cells. So CD19 is a B cell marker. That has to be positive because plasma cells are coming from B cells. And plasma cells are white blood cells. Now, every white blood cell is LCA positive, CD45. So this is the parental origin. Plasma cell is a white blood cell. It has to be LCA positive. Plasma cell is a B cell. It has to be 19 positive. ये तो उसका lineage है, उसके parents हैं. But then it has to make its own identity. 38 and 138 is its own identity that it has. So what did a good son do? Good son or daughter took care of his or her parents also, took care of him or herself also. But what did a bad son or a daughter do? Did not take care of the parents, forgot the parents, forgot CD45, forgot CD19, selfish, only took care of their own markers, and only 38, 138 positive. I hope everyone has understood this story. So good son remembers the parents, bad son forgets the parents, and that is what it has forgotten over here. So this is the table of CD markers, which takes a lot out of you. Quick revision: 19 positive, 45 positive, then 38 and 138 positive is plasma cell. But 19 negative, 45 negative, only 38, 138 positive, multiple myeloma. So many stories we have to do in life in order to learn this table, but once you spend the 5 minutes on this table, your life becomes so smooth and so relaxed, because now when I ask you these flow cytometry graphs, tell me something. What was this? Why did you get it wrong? CD for 34. 34 is a blast. If it's a blast, you can never ever think of CLL. CLL is not a blast situation. So koi to blast hai, ma'am. And 1333 you has told us was a myeloid lineage, and I am getting all the cells in this quadrant. This is the double positive quadrant. Means blast bhi hai, myeloid bhi hai, so my answer becomes AML. How simple is that? Do you want to practice one more question? This is the easiest one that we have. You cannot have a simpler question than this. Look at the markers, 55 and 59. Where are majority of the cells present in this quadrant? Very low expression, very low expression. Everything is negative, 55 negative, 59 negative. Anyway, ma'am, if I would have got 55 and 59, there is no other answer only that I can think of. It has to be a case of PNH. My common sense tells me that. Okay, let's pick up this. What is, you have to analyze both of them. Analyze both of them. You say, ma'am, there's no arrow put. Pick up the quadrant where maximum cells are there. Jahan bhi maximum cells hai, that is what you start analyzing. So this is CD5 and 23, and all the cells are in the double positive quadrant. So patient is 5 positive, 23 positive. Yes. Okay, over here again double positive quadrant, 5 positive, ये तो पता था, 200 positive. अरे मैम सब कुछ has come positive. सब कुछ वाला positive person was always CLL. Correct? Got this also, as I can see. Now everyone 100% correct answer. So इसका variation बताओ. Tell me a variation out here. What do you think this is? Now the quadrants have changed. Be a little cautious. What is this gonna be? Okay, so I see cells over here and cells over here. So what do I analyze? This is very close to the x-axis. So x-axis to definitely is high. CD5 is positive, but it's very low on the y-axis. This means CD23 is going to be negative. Next, over here again CD5 is going to be positive, but it's very low on this axis, means CD200 is also going to be negative. So only one thing is coming positive, and that is CD5. What is that situation? Why did all of you say marginal zone lymphoma? Guys, margin mein you had to forget everything. Margin to bilkul margin pe hai na, so you tend to ignore, wo cut jayega. Everything is going to be negative. Over here one thing is coming positive, and that is going to be mantle cell lymphoma. This is a case of mantle cell lymphoma. In case by chance I feel you guys are having a problem with the quadrants, so jaldi se have a look at this story that I'm going to tell you, because now after this you will never, thoda graphs mein chalte hain, go back to school. You will have one marker written over here, one marker written over here, hai na? If you have cells in this quadrant, this is your DP quadrant, everything A and B both will be positive, double positive quadrant. If cells are over here, this is the most chota wala quadrant, double negative quadrant, A and B both are going to be negative markers. If you get cells over here, see, now keep tracing, just as school mein you used to do, it's very, very high on the x-axis, but it's very, very low on the y-axis. This means very high over here means that jo B hai, that is positive, but very low on this axis means A is going to be negative. So simple, wherever it's lying, whichever axis it is closer to, that axis becomes positive. So if it was lying over here, ma'am, over here, it is very, very close to this axis. This means A will become positive and B will become negative. So simple, this is both positive, this is both negative, this one is closer to x-axis, so x-axis positive, this one is closer to y-axis, so y-axis positive. Revision of graphs bhi ho gaya, because many of you got this wrong, and I don't think now you should get it wrong anyway. CD5 is positive in both the situations, but other markers are negative. This is a case of mantle cell lymphoma. Yes, one last practice question. Let's see if you were listening to me. What is this? BALL, reactive plasma cells, neoplastic IgM, matlab multiple myeloma, or some neoplastic plasma cell problem, and the B cells. What is this gonna be? Analyze both. Cells are here, cells are here. Okay, so I can see you are talking about multiple myeloma. Okay, most of you. Why do I say that? Ma'am, 38, 138. This is the quadrant double positive. So CD38 is positive. 138 is also positive. Every plasma cell will show me that. The good boy and the bad boy, everyone has their 38, 138. What I have to say is, does he remember his parents? So my main concern is, does he remember CD19, who was his parents? And he doesn't. Look at this, the cells are over here closer to 38, not CD19. CD19 is negative. He has forgotten his parents, and if he's forgotten his parents, bad boy. That is going to be multiple myeloma. That is going to be a cancer. Are we clear with this question also? All your flow cytometry, ab jab itna kuch pad liya, all these flow cytometry graphs you have done, then tell me what is this in a flow cytometry that you're going to think of. 1, 2, 3, 4, 5. 5 questions batao and you are sorted with flow cytometry. Question number 1. What is the principle on which it is based? Why are the cells falling one by one? Why are all the cells not falling like in a clump of 20, 40? Because that is the principle known as hydrodynamic focusing. Question number 1. Hydrodynamic focusing is going to be the question 1. That is the principle on which it is based. What is the laser light that we are putting on top of it? I can see many of you have answered it. Laser light is you can see that, ma'am, blue color laser light hai, so they will not ask me this question. 488 nanometers is the wavelength. That is what they'll ask me as a question. Question number 2 bhi ho gaya. No one is wanting you to learn the colors of these blue, yellow, green, the names of these. We don't want you to learn. We always want you to learn the green color fluorescence anywhere. Whether you use it in a fluorescent microscope, whether you use it over here, the fluorescent wala stain is always going to be FITC, and that is everywhere fluorescence comes, you say copy paste kar dena. FITC is the fluorescent color. So that is question number 3. Now comes question number 4. Light is going forward, light is going sideward. So what is it? Light is going forward, that is forward scatter. That depends on what? That is going to depend on size. Chota sa cell hai, little bit of forward scatter. Big cell is there, too much of forward scatter. So more the size, more is going to be the forward scatter, right? Forward scatter is a measure of size. Very famous question. Last question, guys. Side scatter is a measure of what? The light that is going all towards the side. How complex is the cell? How many granules does it have? So side scatter, either they will say is a measure of granularity, or you can say how internally complex the cell is. So it is a measure of complexity. Simple. Repeat. Forward scatter for size, side scatter for granularity. More the size, more the forward scatter, more the granularity, more the side scatter. This is, so you have to mug it up, because I can't even count how many times this question has come previously. Yes, sorted. Flow cytometry, full confidence aa gaya. Shall we move on to the next one that we have? And first you will have to obviously attempt one question for me. Then you know what we are moving towards, platelet aggregometry. What is false regarding Bernard-Soulier syndrome? Large platelets, GP1B9 defect, ristocetin aggregation normal, platelet aggregation in response to collagen and ADP is normal. Tell me the wrong statement that you have to pick up over here. Platelet aggregometry, that's what we discuss. Okay, I can see C and D as expected because it was a platelet aggregometry question, but majority of you say C. Okay, I agree with majority of you. So first and foremost, there are two diseases. Pehle, before I get into this ocean, and which I'm going to do in again a time boxing frame of 5 to 7 minutes, I want, tell me the defect of Bernard-Soulier and Glanzmann thrombasthenia. Wo wala defect, please tell me. Bernard-Soulier is a problem in what? GP. It is a GP1B9 defect. It is a GP1B9 defect. And Glanzmann thrombasthenia is a GP2B3A defect. GP2B3A defect. Guys, what am I talking about? Platelets. Acha, right now when we were discussing that PUBG wala gun, megakaryocyte is what? Megakaryocyte is platelet ka hi mother and father, na? So megakaryocyte is the parent and platelet is the baby that comes out of it. So if you said that megakaryocyte had markers of the PUBG gun, that is 4161, then this means platelets also have the same markers, ma'am, 41 and 61. So what is 41 and 61? GP2B and 3A. GP2B and 3A is nothing but the same megakaryocytic wale PUBG gun wala markers, 41 and 61. So that means that before I get on to platelet aggregometry, there is one aspect that I have missed out. and that is this. Now I can tell you, look at what they've written. They can give flow cytometry for everything, WBC, platelet, RBC, anything. 41 is written, 61 is written. You'll say, ma'am, ये वो 4161 वाला gun है, GP2B and GP3A, and all the cells are in which quadrant? All the cells are in double negative. When GP2B and 3A are not there, what is the disease that I'm talking about over here? Glanzmann thrombasthenia. So how they've integrated flow cytometry with platelet, that is something which only an INI-CET exam can do. And coming all the way back, please in the paper don't get confused. Which one was GP1B9, which one was GP2B? So first number pehle rakho, 2 and 3 later on, and same for the alphabets. B comes first, G comes later. So B is gonna go ahead with 1B and G is gonna go with the other numbers. Alphabetically and number wise, you have to follow the order. Now, B for B, Bernard-Soulier shows you bada platelet, big platelet. So if they say big giant platelets are seen, that is correct. Coming back to my question, does Bernard-Soulier show you bada big platelets? That is correct. Does it show you the first defect, GP1B9 defect? That is also correct. अब बाकी सब options क्या है? Ristocetin and platelet aggregation. So this is what I am talking about. All this is done in a machine. We don't have to do anything. We just have to put a sample and a chemical, and everything is done by a machine. My work is that I have to read the end graph. So you should know what is the starting and you should know what is the ending. You don't know what the machine is doing in between. That is not required. So you need to understand principle kya hai. What is the principle based on? If they ask you as a single line, remember the principle is light transmittance. Firstly, please ratlo. This is something you will have to ratta lagao, that in a platelet aggregometry or aggregometer, the principle is going to be increased light transmittance. Means what? Look at this. This is a normal sample. Acha, tell me one common sense question. It comes in the paper, but sometimes we forget our common sense in the exam. Platelet study कर रहे हो, what is the sample you would want to take? Platelet rich plasma or platelet poor plasma? What will you want to take? So the sample, blood sample, of course, ma'am, if I have to study the platelets, I will need the platelets. I will need a platelet rich plasma. This is the simple question that has come in the paper, but students get confused listening to, oh, PRP was there. I don't know what is PRP. And what is PPP? Platelet poor plasma. That I'm not gonna take. I need the platelets over here. I will take a platelet rich plasma. Okay, so now these are all, can you see these dot dot dot? These are all the platelets. Till the time all these platelets, imagine all these platelets are standing over here, will they let any light pass? No, ma'am. All the light is getting blocked. Hardly any light will be able to go through. But if I aggregate the platelet, aggregation kar diya, if they become chota chota aggregated clumps, now will there be space for the light to go through? Yes. So light transmittance is the principle that you have. That is the principle for platelet aggregometry. I have to make these clumps. How do I make it? So number one chemical that I add is ristocetin. वो एक family है. And the second family that I add are all these. ADP, epinephrine, collagen. Means ristocetin is going to test for that GP1B9 wala thing. Matlab, what is the GP1B9 defect? Bernard-Soulier syndrome. Whereas all the others, ADP, epinephrine, collagen, they are going to test for GP2B3A. This means they are going to test for Glanzmann thrombasthenia. This is the ratta that you do. If you've learned this, the graph is a 1-minute cakewalk for all of us. Ristocetin is the first wala step, that is GP1B9, Bernard-Soulier ke liye test hai, and all the others are a test for GP2B3A, that is Glanzmann thrombasthenia. Have a look at the first graph that we have over here. This is what, see, the best part is they don't have too many graphs of platelet aggregometry. They have the same graphs on Google, same in the textbook, so there's no possibility of a variety coming out here. This is the same graph they're going to copy paste either in colored or in black and white format, but aayega yahi. So in this you need to understand, you will have one blue color line. Blue is the simple color, so blue color line will always be for a normal person. They have taken some normal person's blood sample, and red is always the color of alert. So this must be the sample of the patient. Even if they don't give you the color coding, it is understood. Blue hoga normal, red will be alert for the patient. Initially, everyone's sample is normal, abnormal, koi bhi hoga, sabka sample. Optical density is 100%. What do I mean by that? Common sense again. Initially, everyone's sample looks like this. Lots of platelets, platelet-rich plasma, dense, very, very, very dense, 100% optical density sample for everyone who has started the test, whether it is a normal person, whether it is a diseased person. Now I have started adding some chemicals. Can you read ये छोटा छोटा ऊपर क्या लिखा है? Ristocetin has been added, ADP, epinephrine, collagen has been added. So now I know I can divide this into two parts and I can read ristocetin was for what? Was for GP1B9 testing, that is for Bernard-Soulier syndrome. And what I see over here, कि the patient and the normal are not the same. Defect आ गया है. There is a problem in the patient. He has not shown me the test with ristocetin. This means what is the disease that he might be suffering from? That is Bernard-Soulier syndrome. Now I want to tell you a little bit extra information. Very good. Dr. Arun says, ma'am, this could also be von Willebrand disease. Why can this also be von Willebrand disease? Because now I want to ask you, go back to your platelet chapter and tell me, GP1B9 bind किससे करता है? It binds to von Willebrand factor. So if GP1B9 is missing, then also patient will have the same problem, and if von Willebrand factor is missing, then also it will have the same problem. So the same test will come for GP1B9 problem also and will come for von Willebrand factor problem. This means 1B9 problem was Bernard-Soulier syndrome, von Willebrand factor is von Willebrand disease. So von Willebrand disease also shows you a ristocetin problem, and Bernard-Soulier syndrome also shows you a ristocetin problem. You are right, that is an adhesion defect. बाकी तो you will say, ma'am, look at this. Other बाकी सबका red and blue match कर रहा है, मतलब वो normal है, not a problem. The only problem came was with ristocetin. Look at the other graph. This is the only other graph possible. After this you are settled. You will say again, ma'am, blue color matlab it must have been the normal person, and red means it is the patient. Now can you see ADP, epinephrine, collagen, the graph hasn't moved only. कुछ भी नहीं हुआ है. From 100% it has hardly come to 90%. It has not moved. It has not shown any response to ADP, epinephrine, collagen. What is this a problem in? This is gonna be a problem in GP2B3A, and that means it is a case of Glanzmann thrombasthenia. A question that will come is कि ma'am ristocetin also कोई matching तो नहीं हुआ ना? It has not like completely overlapped, because you need to understand that if no aggregation is occurring, how much will ristocetin has done considerable work. देखो, considerable optical density has fallen, but it can't come down to a normal zero like a normal person, because there is nothing beyond it that the body is accommodating. There is nothing beyond it that is happening. तो थोड़ा reaction तो आया, little defect has come, but I ignore it because the primary defect that I see over here is definitely in the the aggregation, the GP2B3A. तो अब simple take home message क्या है? If I see a problem in ristocetin, either it is Bernard-Soulier or it is von Willebrand disease, ristocetin का problem. If I see a problem with ADP, epinephrine and collagen that I see over here, it is going to be Glanzmann thrombasthenia. Are we okay with this? One of the most dreaded things that you guys have, and you feel that it is very, very difficult to do. I hope we have managed to finish it. Yes, confident about it. Coming back to your question, tell me, for Bernard-Soulier syndrome, is the ristocetin test normal? Of course not. Ristocetin test is going to become abnormal. That is why this was the answer. And next, for Bernard-Soulier, is reaction to ADP and collagen? हाँ, वो Glanzmann के लिए था. They are gonna be normal. But this third wala option is false. Ristocetin cannot be normal. I hope this is settled for everyone, because almost we are coming to the end. As I had promised, it's going to not be some 3-4 hour session, and thank you for the cooperation, because you have managed me and helped me in finishing all these bulky hematology pack in such a limited time. Last one is quick revision of 5 to 7 minutes time boxing that we do for vacutaneous. Shuru kare? Yes, last part, last run towards the end of this hematology pack. Let us begin with this. What is your answer? The bread and butter of a pathologist, of a path lab. No one can survive without it. The purple vacutainer. Yes, the purple vacutainer. What is it? Any other miscellaneous questions? Bas after this we will take up. Any other topics you want that should be covered, wo bhi end mein bata dena. We can take that up tomorrow. But abhi wrap it up first and then we'll talk about it. Most preferred anticoagulant in the vacutainer. Yes, EDTA to hai, but kaun sa EDTA the most preferred is? K2 EDTA, guys. K2 EDTA is the most preferred one that you have. So now, because you're going in for INI-CET, knowing just this much that, oh, this purple vacutainer is EDTA vacutainer is not going to be enough. You need to know all the vacutainers that have EDTA. There are lots of colors. For every purpose, they've got a different color. Imagine all of these colors, they are different colors, but all of them have the same EDTA salt in them, the same EDTA. So of course, how will I learn so many colors? Story. When mnemonics, when ABCD wala mnemonics get saturated, then you come to nice cute little stories. So I will introduce to you a girl named Pearl. Pearly white girl. So she's so white, she's so light skinned, so white. White people always want to get a tan. They always want that we should get our skin tanned. So she wants a tan, and she is very white. She belongs to the royal family. And her every girl, what is the girl's favorite color? Either pink or purple. So introducing to you Pearl, who is a white girl who wants a tan, who belongs to the royal family and loves the colors pink and purple. That is all containing EDTA. For what purpose will I use what? This I don't need to know. Come on, this you know. The bread and butter of pathology is done in purple. Whether it is a complete blood count or a peripheral smear or a reticulocyte count or ESR by the Wintrob's tube. ESR का बाकी सारा also we will do, but अभी के लिए ESR by Wintrobe. So ma'am, all the day-to-day वाले tests have to be done in purple. Pink. Pink is a very sensitive, girls ka favorite color, very sensitive color. So that part of the hospital which is very sensitive, the blood bank samples have to be sent in the pink vacutainer, sensitive color hai. Tan, how I have learnt is, tan sounds like tin and tin means lead. So whenever you're suspecting a case of lead poisoning, tan vacutainer is what you're going to use. Tan, tin, lead. Finally, coming to royal family matlab, royal family to very rare na, very extraordinary, very rare. So something very rare will be measured in it. Royal blue vacutainer mein some rare elements is going to be the trace elements, copper, zinc, these trace elements will be measured. And finally, P for pearly white girl and P for PCR samples. They are going to be sent in pearly white. So remember the story of Pearl, who wanted a tan, who loves pink and purple, and who belongs to the royal family. All of them are going to have EDTA. Okay, now coming to the next question. What is your answer? जल्दी सबका anticoagulant बताते जाओ and keep finishing it off so that in 5 minutes we wrap it up. What is the anticoagulant in this light green, dark green? So green matlab hara and hara means heparin. That is how we learn it, right? Hara means heparin, right? So remember, heparin is what is used. One very valid question has come, ma'am, I have never used so many vacutainers. I have done all these tests in a single vacutainer. So have I. Honestly telling you, so have I. I have tested lead also in the same purple vacutainer, the blood bank sample also in the same vacutainer. Some things are left for the book and left best for the book because we don't have supply of so many rainbow colors in every hospital, especially in government setup. So purple hi mil jaye, that is such a big achievement. How will you ever catch hold of pink? Till the time I was in a government setup, I myself had never seen any of these colors. These were all limited to textbooks. Anyway, coming back, we are coming to hara, and hara is heparin. So now please remember, there is a light hara and a dark hara. Light hara, Li is going to be lithium heparin. Dark green, Da, is going to be Na, sodium heparin. So remember, heparin will be hara, green. Light is lithium and dark is sodium. What are they used for? Earlier they were used for a lot of things. You know, once upon a time was osmotic fragility testing. Again, no one does osmotic fragility testing now, but who does osmotic fragility testing? The examiner loves to do osmotic fragility testing. For which anemia? For hereditary spherocytosis. So once upon a time, OFT samples were collected in this hara vacutainer. Now no one is interested in all this. Now only one thing is done, ABG. Yes, heparinized vial is going to be ABG, arterial blood gas analysis. Arterial blood gas analysis is going to be done in the heparinized vial. Okay, this is also sorted. Hara vacutainer heparin. Quickly tell me the answer to this. What is the most preferred anticoagulant in the vacutainer over here? ध्यान से पढ़ना, please do not make an error. I think I have taught you this before NEET PG also. You should not ideally make an error in this question. What is the most preferred anticoagulant? And I was expecting that error. Everyone is like sodium fluoride. Dekho. Firstly, what is this vacutainer? This vacutainer is a gray top vacutainer. Gray matlab anything that I have to measure for glucose, right? Anything that I have to measure for glucose, I am gonna do gray top. Glucose matlab fasting blood sugar, postprandial blood sugar, glucose challenge test, oral glucose tolerance test, koi bhi glucose, you say random glucose, everything is over here except one. Do you do glycated hemoglobin, HbA1c over here? That is also glycated, but it is glycated hemoglobin. You are relying on hemoglobin and red blood cells for the measurement of the sugar. So that you cannot do over here. That you can't do over here. That is not done here. That is done in the bread and butter, the usual purple wala EDTA. So now I can go all the way back, and in EDTA I can add that HbA1c testing is also done here. After that, every other sugar testing, glucose testing is done in gray wala vacutainer. So now this actually has two things. You have to read the question carefully. I asked you what is the anticoagulant. Guys, anticoagulant is potassium oxalate, not sodium fluoride. Sodium fluoride, which inhibits enolase, that is an additive. दो चीजें हैं इसमें. I asked you what is the anticoagulant. Anticoagulant was potassium oxalate. If I would have asked you what is the additive, then you would have called it sodium fluoride. So please remember this and read the question very, very carefully. This is a trap in which the examiner will try to put you in. Coming to almost the end, what is this one? The very famous light blue vacutainer. Light blue vacutainer is 333, matlab there is trisodium citrate 3.2%. Trisodium citrate 3.2%. What will I use it for? For number one, coagulation studies. You keep asking what is PT, APTT done in, all those coagulation, PT, INR, yes, all of that is there, perfect. And other than that, ESR, but by which method? ESR by the Westergren method. Where were you doing ESR by the Wintrobe method? तो ESR का एक story बना लेते हैं so that we don't get confused. If I have ESR which has to be measured, you say my hospital ma'am has Wintrobe tube. If your hospital has a Wintrobe tube, I will suggest that you get your blood collected in the EDTA. You know, this also no one ever teaches us in internship. I was also totally unaware. ESR करने से पहले you are supposed to call your path lab and ask what is the methodology of ESR that you are using, because I will send my sample accordingly. But I don't remember doing this in internship. We used to just send the samples left, right, center in any vacutainer. Such a wrong thing to do. But yeah, Wintrobe से कर रहे हो तो you will send it in EDTA. If you have this blue vacutainer, that is what the ESR estimation for Westergren. ESR estimation for Westergren, that is going to be done in the light blue vacutainer. That collection will be done in light blue. And what is this black color? You know, this black color also has the same. जो light blue में क्या था? Light blue had trisodium citrate. You know, the black one also has the same trisodium citrate. Then why have they given it a new color? Because this is a very, very patla tube. It can go inside a machine. So this is the one that you are going to use for automated ESR, because it's a very thin tube, na? It easily goes inside a machine. So that's the only difference. Otherwise, the anticoagulant is trisodium citrate in both. So now you have got all the answers in front of you. Quick revision. Wintrobe is asked, so EDTA. Westergren के लिए obviously you are left with light blue, and if you have a very, very patla sa black color needle, black color vacutainer, that is going to go into the machine, automated. Almost coming towards the end, because now I want to know, that is where I don't have an anticoagulant. Ma'am, I don't want an anticoagulant because I want to study serum. I want to do serum, say for example, all the hormones, serum T3, T4, TSH, beta HCG, prolactin, SH, FSH, LH, all these hormones I want to do. Along with that, I want to do LFT, KFT, serum urea, serum creatinine, all those enzymes, enzyme studies. For that I need serum. Please make the blood clot. Let the blood clot. If the blood will clot, only then will the serum come out. Then only wo yellow color ka serum is going to come out of it. So number one, I've got a red vacutainer for it, I've got a yellow vacutainer for it, and I've got an orange vacutainer for it. Now many people, again, I'm telling you things which I myself have done, committed mistakes during my internship. They say blood ko clot hi to karana hai. So when you, for example, if this is your vacutainer, you collect it, and in every other vacutainer, in all these other vacutainers, you're supposed to mix the blood and the anticoagulant. We were told that these vacutainers don't have anything, just collect the blood and keep it on the side. There's no need to mix it. And that's a mistake that we are doing. You are supposed to mix these also. You are supposed to invert and mix the blood in this also. Why? Because even in the red vacutainer, you have something known as a clot activator. Both of these, all of these in fact, they have something known as a clot activator. You have to mix it. And how many times? Very, very good. The mixing in this, I'll tell you the mixing also for all of them. Mixing in this is approximately 5 to 6 times. So 1, 2, 3, 4, 5, 6. Mixing karna hai. That is to be done because they have clot activators. But remember, the yellow one extra has a gel, And the orange one further has a thrombin gel. Why have these extra things added? Because red wala, which had only the clot activator, will take 60 minutes for the blood to clot. The yellow one, I have added an extra gel, so this time only 30 minutes will be taken for the blood to clot. And orange is like, I have never seen orange, even as a pathologist, I have never seen orange. But orange Vacutainer, they say, only takes 5 minutes for the blood to clot. Okay? So remember, as you are adding more and more things, you will eventually realize that the blood clotting will become faster and faster and faster. But in most hospitals, we have red, in which 60 minutes ka clotting time hai, full clotting, and yellow is also used in many hospitals where it is 30 minutes. Okay? Everyone is sorted, and with this, how many times are you mixing? 5 to 6. Baki sab mein kya mixing tha? So let me make a quick table over here for you. For all the EDTA, E aa gaya na, so how many times do you are mixing? The mixing is going to be 8 times. Okay, for all these serum separator tubes, matlab abhi jo pada, that is red, yellow, orange, all these you are going to go in for सीरम. जहां पे सीरम है तो प्लीज रिमेंबर 1 2 3 4 5 रफली 5 to 6 टाइम्स हमने मिक्स करा. What about that trisodium citrate? When everything was tri, if you remember, trisodium citrate was what? Light blue. The light blue wala Vacutainer was trisodium citrate. So when everything was tri and it was 3.2% trisodium citrate, then the inversions are also going to be roughly 3 to 4 times. Easiest to learn, है ना? So remember, EDTA में क्या है? EDTA is gonna be 8 times. Serum wala tubes are 5 alphabets, so 5 times. And trisodium citrate and tri percentage wala is going to be 3 to 4 times. Are we sorted with this? Because that marks the end of your Vacutainers also, and that also marks the end of the hematology special pack that we had, but only for today, because we are gonna meet tomorrow as well at 4 o'clock. So I think we finished well in time. Yes, which is there. And anything else that you want to, let me know, anything you especially want me to include for tomorrow's test. Although tomorrow's session, I've got a mixed bag of, again, INI-CET special images and questions which are pertinent to systemic path, little bit from general. General you've done many times, necrosis, apoptosis, so bahut baar you have seen photos. But things like pap smear, you never see for INI-CET, it's very important. So those kind of pictures I've got for tomorrow, which I'll be covering at 4 o'clock again. Okay, some of you have requested TEG. Are you willing to sit for another 5 minutes? Kar le, TEG karoge, abhi karoge, kal karoge, Lord, your wish. If you want to do TEG, then I can do TEG right now. I have that image, that's why I'm saying. Padhoge to abhi kar lete. Never mind. If you are willing, and if you still, I very rarely get to see such a excited bunch of students for TEG. Usually people run away for TEG. Now we are doing TEG. Chalo. Okay, let's extend for another 5 minutes and let's finish off. TEG, I think, since you're asking me, itna basic to everyone knows. Last 5 minutes, guys. Thromboelastography. Thromboelastography, that is TEG, is a test which is going to be done, is a kind of a rapid test, because other tests in the path lab take a lot of time for the report to come. PT, APTT, this is done by surgeons and anesthetists in ICUs and bedside, because it's a chota sa portable machine which can be kept, and if you know how to read the graph, then your life is sorted. You can take out the analysis very quickly and rapidly. Okay. So now the only thing that you have to know over here is this very, very bad graph that we have. So we are going to do a graph, and at the same time we will also know the different timings that we have. Okay? So pehle to order yaad karo. This is a graph that I can see. This is a graph that I can see that has formed over here. The first part of the graph is taking blood clot banega. The blood is clotting. The second part of the graph is seeing how much of blood is breaking. So this analyzes both. If they ask you, thromboelastography is a measure of clotting or is a measure of fibrinolysis, what is your answer? It is a measure of both. That is why it's such a nice test. It can measure both. तो क्या करते हैं इसमें? You can see you have taken the blood over here and you have put it in a cup. There's a छोटा सा cup over here in which you have put the blood, and there is a needle, very tiny little needle, which is going to come from the top, and you will see this cup is rotating. This cup is ऐसा small angles पे it is rotating, and there is a needle from the top which has come, right? So as the cup will rotate, you know where the blood will clot? The blood will clot on the tip of this needle. Imagine something is getting clotted over here. Will I start pulling the needle down? Gradually there will be pressure on the needle that will start coming. As and what the pressure comes, this pressure is transmitted to the machine that someone is trying to pull me down. Clot ban raha hai, it is trying to pull me down, and that pressure is read by this machine and converted into this graph. That is the basic. This is only for your understanding that how is this working. This principle no one will ask you. Ab pehle please analyze R, K, alpha, MA and L by 30. Actually there are just 5 things, and you need to know 5 normal values that will come. So please note, when I talk about R, it is nothing but the reaction time. How much time does it take for the clot to form? So who is going to make the clot? The clotting factors are going to make the clot. So R time, reaction time, is going to be the time that is taken by the clotting factors. It is roughly 4 to 8 minutes. Some books have mentioned 5 to 10 minutes. Around this only it works. Okay? 4 to 8 minutes. After that you say, ma'am, the next chota sa time that you have is the K time. What is K time? I have learned K for Kadak. That is how I have learned it. Kadak means how strength or how strong is your clot. What is your clot strength? So please remember, if you want to measure the clot strength, and clot strength depends a lot on fibrinogen. So this is actually going to measure the fibrinogen. So please remember, the K time is going to be for Kadak. How Kadak is my clot, how strong is my clot. After that you have the graph is going up. See, whenever the graph is going up, matlab angle ban raha hai. There is an angle formed. So obviously that is going to be alpha angle. Right? Before that K time क्या था? तो ये याद रख लो, if R time was 4 to 8, K time उससे छोटा लग रहा है मैम, less than 4 minutes. Make it somewhere around 1 to 4 minutes. So it's basically going to be lesser than the R time, right? Now the graph is going up. That is going to be the alpha angle. This is also going to be a measure of fibrinogen. So this is also, so can you see the graph is going up? Ma'am, the graph is catching speed. It is like uphill. The car is moving uphill. So speed se upar ja raha hai. So the alpha angle is going to tell me the speed of clot formation. How fast is the clot forming? Who is going to tell me the normal value of this alpha angle that we have over here? What is the normal value that we have, guys? There's a range. There's a very easy way. Obviously kuch degrees mein hoga, that is going to be there. Jaldi batao, because this was a previous year question. The alpha angle, and after this in the end you'll make a table also before you go. It is roughly between 4474. That is how I've learned it. Thoda plus minus variation you will see in the books, but way of learning is this 4474. So that is going to be 44 degrees to 74 degrees. That's a wide range that they have provided. As I said, some of you are saying up to 60, so you've taken out averages. So I'm telling you what is being said in most of the books as a range. Okay, now after this, ma'am, here is where the clot reaches the MA. MA stands for maximum amplitude, peak. Peak किसकी वजह से आता है? So remember, maximum amplitude is because of a peak, and peak is because of platelets. That is the question that came in the NEET PG exam, where no one expected TEG to be asked. So please remember, platelet tell you the peak, but it's not the platelet. The question was, are maximum amplitude only dependent on the platelets? No. Maximum amplitude is more commonly dependent on the platelets than the clotting factors. So if you had to select one thing, peak ke liye remember P for peak, P for platelet, but also clotting factors have a role. After the peak, there will always be downfall. Downfall means there is going to be fibrinolysis. Lysis means L by 30. After 30 minutes, how much of lysis has occurred? And that is going to be 0 to 8%. So I'm going to give you a very quick analysis of this once again. R time, major wala time, chota wala time, K time, then there's an alpha angle, then there's a maximum amplitude, and then it's gonna break off. So jaldi se tell me the sequence and then tell me the values. Sabse pehle we have R time, reaction. This is the time that takes for reaction, which is going to depend on what? It is going to depend on the clotting factors. Everyone 2-minute revision and we are free for the day. This is going to take how much time? 4 to 8 minutes. Now comes the K time. K Kadak. Kadak means it is going to tell me the clot strength. How strong is the clot? That is going to be somewhere between 1 to 4 minutes, and it is dependent on what? It is dependent on fibrinogen. Next comes the car going uphill. Uphill means there is going to be an angle that is formed, alpha angle. Alpha angle is going to be telling me uphill matlab car ki speed बढ़ रही है. It is telling me the speed. It is also a measure of fibrinogen, and the normal values is a wide range of 44 degree to 74 degrees. Then comes the final maximum peak, maximum amplitude. Peak is going to be determined by what? Peak is determined more commonly by platelet, a little bit by clotting factors also, but primarily platelets. And finally, the car is going to fall down, that is LY30, that is going to tell you lysis at 30 minutes. LY30 is lysis at 30 minutes, which should be 0 to 8%, 0 to 8%. So individually to yaad ho gaya, but what is the famous mnemonic which you will find in your one of your favorite books, and what is that? R.K. Ranbir Kapoor is an alpha male. That is what you get in your textbooks. So R.K., that is Ranbir Kapoor, is alpha male, which means that R.K. reaction time, K time, alpha angle, maximum amplitude, and LY30. That is the sequence that you have. Okay? R.K. alpha male is what you are going to learn. Sorted. This is all that you had to know, of which such a big deal has been made in the books and such a big deal has been made by the students also, but I don't think it is. If you know this mnemonic, if you know the sequence, and you know the timings and how this graph is going, it is pretty simple to learn it. It's not at all a tough deal. Sorted. So you guys wanted TEG for the day, and so it is done, which genuinely makes us wrap up this session in the true sense. True hematology pack over. But yes, I'll be meeting you tomorrow at 4, and I've already told you in the beginning of the session what are the different things that you should be looking at. As a time crunch is there, you have to focus on this in priority wise. Okay? Fine. Electron microscopy, Dr. Vijay, whichever are the essential ones, I will definitely show you tomorrow. But should I tell you one rule of INI-CET exam? No matter how many electron microscopy pictures you see and go, one will always be out of syllabus. That is the rule of this exam. So I will show you obviously the ones that are important, but be prepared that for everyone, one picture will always be out of syllabus. Okay, and don't worry, you guys are doing well. It's just that little bit of lag happened after your NEET PG exam. So that is the reason that you took time to get back on track. But you've done it earlier in NEET PG. You know how it works. You know what to do for the INI-CET. It always revolves around your rapid revision, your notes, and INI-CET has more emphasis on previous year topics than any other exam. They have the same pool of topics. They will just keep recycling them. You've seen that in previous years also. More than NEET PG, it is INI-CET which focuses on their really, they are very possessive about their topics. They don't leave their topics so easily. So they're definitely going to give you the same platelet aggregometry, TEG and all. They're just going to recycle those questions. So don't just think of reading anything new. Don't think it's INI-CET, so I have to sit down and start reading some journals and articles and whatnot. You have to read those specific INI topics which are important, right? Correct. Thank you so much for joining in. See you all tomorrow sharp at 4 o'clock. Thank you.